Good day, our dear students. Uh, Today our second lecture, and today we will talk with you about classification of tuberculosis, primary tuberculosis, disseminated tuberculosis, and tuberculosis meningitis. What about clinical classification of tuberculosis? Firstly, we must identify the type of tuberculosis process. It may be first diagnosed tuberculosis, it may be tuberculosis relapse, or it may be chronic tuberculosis. Secondly, we must talk about clinical forms of tuberculosis. In clinical classification, divided into some pieces. Firstly, it is lung tuberculosis and its forms: primary tuberculosis, disseminated tuberculosis, nidus lung tuberculosis, infiltrative lung tuberculosis, caseous pneumonia, lung tuberculoma, lung fibrous cavernous tuberculosis, lung cirrhotic tuberculosis, and also tuberculosis of respiratory organ combined with dust professional diseases called coniotuberculosis. Thirdly, we must tell about characteristic of tuberculosis process. Firstly is localization of defect. Localization of defect in lung according to the number of segment, names of lung section, according to anatomical names of localization of a failure. Second one is presence of destruction. Destruction plus destruction is present, destruction minus destruction is not present. And also we must talk about phase of tuberculosis process. It must be active phase, including infiltration, decay, destruction plus, or sowing. At not active process, it must be suction, consideration, scarring, and calcination. And last one, we must talk in classification about complication of tuberculosis. Complication divided into complication of lungs tuberculosis and complication of extrapulmonary tuberculosis. For example, complication of lungs tuberculosis is hemoptysis, lungs hemorrhage, spontaneous pneumothorax, chronic lung heart, atelectasis, and etc. Complication of extrapulmonary tuberculosis is bronchitic stenosis, pleural empyema, and ankylosis, etc. Primary tuberculosis. Primary tuberculosis usually displays in three main forms: tuberculosis intoxication in children and teenagers, primary tuberculosis complex, and tuberculosis of intrathoracic lymph nodes. Pathogenesis in children. Primary tuberculosis is always a result of exogenous infection and penetrate into organism by three ways. It is aerogenic way, elementary way, and contact way. Tuberculosis intoxication in children and teenagers is a clinical form of primary tuberculosis which is characterized by complex of symptoms without local manifestation of disease. Morphological substrate of tuberculosis intoxication are minimal specific and paraspecific changes usually in lymphatic system. In this slide you can see how to make palpation of peripheral lymph nodes. In this slide you can see paraspecific reaction, paraspecific skin reaction during the tuberculosis intoxication. In this slide you can see how to make percussion of danger zone. Is zones called danger because tuberculosis localized always in sub and supraclavicular zone and long to spinal column. That's why these zones called danger zones. In this slide you can see how doctor to make auscultation, also the danger zones, subclavicular and supraclavicular zones. It is necessary how to make diagnosis of tuberculosis intoxication. It must be positive tuberculin skin test It must be symptoms of intoxication. Must be absence of rentgenological change, and it is very necessary excluding of intoxication with different etiology. Only with this is 4 symptoms we made a diagnosis of tuberculosis intoxication. Primary tuberculosis complex. Primary tuberculosis complex is characterized by development of specific general change in lung called primary affect, lesion of intrathoracic lymph nodes, and lymphangitis. In this slide you can see the primary tuberculosis complex. I will show you. This is a primary effect localized in parenchyma of lung. This is a lymphatic nodes inflammation, lymphadeninitis, and between these 2 parts, inflammation of lymphatic vessels called lymphangitis. Clinical manifestation. Our patient complains to subfebrile temperature, decrease of body weight, bad appetite, quick tiredness, coughing maybe, but it is very seldom. During the inspection we can find paleness, decrease of skin turgor, paraspecific changes, and micropolyadenitis. Some patient these changes can be absent. During percussion we can find dullness of over lung component with a big size, weakened breathing. In hemogram we can find leukocytosis and increasing ECR up to 20-25 mm in hour. Tuberculous skin test is always will be positive or hyperergic, and during the X-ray diagnostic we can find 4 phases of primary tuberculosis complex. First one is infiltrative or pneumonic, second phase is resorption, third phase is scarring, and fourth phase is calcification. In this slide you can see first phase of primary tuberculosis complex called infiltration phase, and you can see in the X-ray chest you can see triangle shape shadow. In this slide, in our next slide, you can also see the primary tuberculosis complex and triangle type, triangle similar shadow in the lungs. In the slide also you can see the infiltrative or pneumonic phase of primary tuberculosis complex. Always you can see the triangle type of primary tuberculosis complexes shadow. In this slide you can see phase 2, second phase called resorption or bipolarities. I will show you. This is one polarity, it is second polarity, and between it you can see paths between these 2 components. In the slide you can see phase third phase scarring, and finally you can see phase of calcification. Here you can see calcification of lymphatic nodes, and in our next slide you can see the calcinated first effect, primary effect, and calcinated lymph nodes. It is phase of calcination, calcification. Schematically, phases of primary tuberculosis complex look like that: infiltrative or pneumonic phase, resorption, and calcification. Primary tuberculosis complex complexes complication may be different. Firstly, it is primary tuberculosis cavity. It must be maybe hematogenic dissemination, lymphogenic dissemination, pleuritis, formation in fistula, formation on bronchial tuberculosis or atelectasis. In this slide, you can see some complication of primary tuberculosis complex. First one is pleuritis, second one is lymphohematogenic dissemination, third one is forming of primary caverna. You can see atelectasis of upper lobe right lung, and you can see also the dissemination. Acute disseminated primary tuberculosis. It is example for hematogenic dissemination. You can see in the slide needles of hematogenic dissemination in upper lobe of both of lungs. In this slide you can see complication primary tuberculosis complex as a atelectasis of upper lobe right lung, and schematically you can see also in this slide we start to tell with you about a third form of primary tuberculosis complex called tuberculosis of intrathoracic lymph nodes. It is clinical form at its clinic, similar to that of primary tuberculosis complex. Clinical radiological forms, So first one, small form, deformation and straightening of pulmonary picture near lung root, decreasing of root structure. Second one is infiltrative form, and third one is tumor shape forms. In this slide you can see tuberculosis of intrathoracic lymph nodes schematically. You can see the enlarging of lymphatic nodes of bifurcation and bronchopulmonary group of intrathoracic lymph nodes. In this slide you can see X-ray of lymphadenopathy or primary tuberculosis complexes 1 third form intrathoracic lymph nodes. You can see the enlarging of root of lungs. In this slide you can see also tuberculosis of lymphothoracic lymph nodes, how it is look like in a rentgenological examination and schematically. In this slide you also see of tuberculosis of intrathoracic lymphatic nodes, infiltrative form. You can see the contours not clear, contours of lungs root is not clear what. And in our next slide you can see tumorous form, and this is a contours of lymphatic nodes. It's clear, and that's also. And we started with you to learn disseminated tuberculosis and tuberculosis meningitis. Disseminated tuberculosis appears during hematogenic dissemination of the infection and is characterized by bilateral symmetric focal lesion which localized in superior and cortical parts of lung. There is acute, subacute and chronic disseminated tuberculosis of lungs. This form of tuberculosis affects bones, kidney, genital organs, larynx, pleura, and more frequently. In this pathogenesis, it must be 3 condition: presence of tuberculosis infection in organism. First one. Second one is bacteremia, and third one of hypersensibilization of pulmonary vessels. In this slide you can see the ways of spreading Mycobacterium: hematogenous role, lymphogenous role, and bronchogenous way of spreading Mycobacterium tuberculosis. In this slide you can see the miliary tuberculosis. In this slide you can see organ involvement in miliary tuberculosis, often in 100% lungs, and spleen 86%, and liver in 91%. This slide shows a pathomorphological picture of multiply tuberculosis, rentgenological changes, and also you can see how it is to as the clinical progress, miliary tuberculosis is conditionally divided into lungs, typhoid, meningeal, and septic forms. Here you can see chest radiography of patient with miliary tuberculosis, not the intensive, symmetrical distribution of 2 to 3 millimeter lesions throughout both lungs, and you can see close-up view of chest radiograph in figure, not the uniform distribution of needles throughout the lungs parenchyma. Bacterial bilateral total hematogenous dissemination, tiny nidus shadows. It is also the miliary tuberculosis. Subacute disseminated tuberculosis. This form of tuberculosis develops during decreasing resistance on organism and senile age during immunodepression therapy. Clinical picture: the start of dissemination tuberculosis can be acute or gradual. In case of gradual start, there are such symptoms: fatigability, general weakness, poor appetite, dry cough, mucus cough, blood sputum, chest pain, and dyspnea. General state of patient changes for the worse, develops circulatory caused by overload of right house chambers. In some cases, onset sign can be varying. Objective investigation is characterized by symmetric dual sound under upper and middle pulmonary parts, auscultation of harsh or vesicular bronchial breathing, moist fine bubbling rails. Laboratory investigation: hyperchromic anemia, leukocytosis, neutrophil evaluation, lymphopenia, monocytosis, elevation of erythrocyte sedimentation rate, and observed in blood picture. MAN2 test is positive. X-ray examination: it is characterized by a large symmetric focal shadow with outlines, total or subtotal affection. These X-ray changes are typically and imitate the picture of dropping snow. When appear lightning with regular shape situated symmetrically in the upper lung segments. In this picture you can see disseminated lung tuberculosis subacute. You can see, I will show you, you can see shadows more in upper and medium part of lungs, not clear contours. Dropping snow, symptom of dropping snow you can see in this slide. You can see this cavernas, stumps caverna, here it is, and here it is. You can see here it is symmetrical, always symmetrically, because develop from the subacute form of disseminated tuberculosis. Chronic disseminated tuberculosis of lungs appears in case of not entirely effective therapy of the subacute disseminated tuberculosis. It observed more frequently as independent form, characterized by presence of temporary remission of disease and acute condition, which is caused by bacteremia, dissemination, and infiltrating change of lungs. Here you can see that schematically chronic disseminated lung tuberculosis. You can see the caverns, you can see the old and young shadows in the lungs. X-ray examination. During hematogen dissemination on the X-ray, we can observe symmetrically situated focal shadow with weak intensity and unclear outlines of shadow. Typical X-ray picture of chronic disseminated tuberculosis formulated during long course. Multi-shaped focal shadows with different intensity in superior and median segment of lungs. Deformation of lung picture. In the inferior segment, we observe particularly clear lung field and poor lung picture with a caused by emphysema. All focuses are situated in the superior segment. They are more intense with well-contoured outlines. Fresh focuses are in the interior segment, characterized by low intensity, deformation of the roots and lungs with superior disposition. Signs of willow branches is observed. You can see chronic disseminated lung tuberculosis in upper lobe. You can see old shadows, and you can see fresh shadows, and in lower part you can see emphysema. Here also pictures and schematically scheme of chronic disseminated tuberculosis of lungs. Differential diagnostic. More frequently, differential diagnostic carries out with bilateral focal pneumonia, carcinomatosis, silicosis, sarcoidosis, pulmonary congestion. For the confirmation of diagnosis of tuberculosis, it is necessary to pay attention on contact with affected person and during of primary tuberculosis, pleuritis, focuses of the superior and cortical segments. Bilateral nidus pneumonia. It is as a differential diagnosis. It is sarcoidosis of lungs and intrathoracic lymph nodes. It is a sarcoidosis of lungs and intrathoracic lymph nodes. How it is look like? It is carcinomatosis. Pay attention that needles and shadows localization in low part of lungs when in tuberculosis, disseminated tuberculosis, our shadows localization always in upper and medium part of lungs. Lungs stagnation phenomena also is upper lobe are clear. It is transudate and stagnation phenomena and lungs transudate. Here I will show you. Here it is transudative reaction of pleura. Tuberculosis meningitis. Tuberculosis is a major case of death worldwide. India has the highest ever burden according to 1/3 of global incidence. Значит, tuberculosis pathophysiology of central nervous system tuberculosis is secondary to disease elsewhere of the body. Mycobacteria reach the brain by hematogenous route. Initial small tuberculosis lesion develop in meningitis, subpial and subependymal surface of the brain or the spinal cord and may remain dormant for the years. It is a pathology. Release of Mycobacterium tuberculosis results in a tail lymphocyte dependent necrotizing granulomatous inflammation response. hydrancephalon, adhesive arachnoiditis, obliterative vasculitis. Spinal form of tuberculosis meningitis might result from a rupture of rich foci in the spinal arachnoid space. The acute form presents with fever, headache, and root pains accompanied by myelopathy. The chronic form presents with spinal cord compression. Spinal form of tuberculosis meningitis may be associated with syrinx formation. Tuberculosis meningitis, commonest form of nephrotuberculosis, also commonest from the chronic meningitis. Clinic features include well ill health for 2 to 8 weeks prior to development of meningeal irritation. Non-specific symptoms include malaise, anorexia, fatigue, low-grade fever, myalgia, and headache. Prodromal symptoms in infants and children include irritability, drowsiness, poor feeling, and abdominal pain. Meningeal irritation, neck stick stiffness, Kerning sign, Biskel sign, and Brudzinski sign. Cranial nerve pulses, fundus, rarely choroid tuberculous. Visual loss may be due to optic nerve involvement, increasing lethargy, confusion, stupor, deep coma, decerebrate, and decorticate rapidly. Clinical presentation: headache, nausea, vomitus, apathy, behavior changes, fever, meningism, cranial nerve palsy, and coma. Stage 1 is prodromal phase with no definite neurological symptoms. Stage 2 is sign of meningeal irritation with sight or no clouding of sensorium and minor. And stage 3, severe clouding sensorium, convulsion, focal neurological deficit, and involuntary movements. Modified MCR criteria, grade 1, grade 2, grade 3. Diagnostic rule for TBM: it is age, it is blood count, history of illness, and count in the spinal CF, and neutrophil. Fundal meningitis, which disease we must make differential diagnosis of TBM. It is fungal meningitis, histoplasmosis, cryptococcosis, blastomycosis, and other viral meningitis, herpes simplex or mumps, particularly treated bacterial meningitis, neurosyphilis, focal parameningeal infection, toxoplasmosis, neoplastic meningitis, and neurosarcoidosis. Cerebrospinal fluid examination we must done. Predominantly lymphatic pleocytosis with increasing proteins and low CSF, blood glucose ratio. FBC count can be normal in presence or depressed. Cerebrospinal fluid examination protein always raise this subscription of tuberculosis of fungal infection. Smear and culture is positive in 70%. It is necessary to make cerebrospinal fluid examination and examination, smear examination, gram smear, culture of solid media, Nielsen and India ink stain. In Bactec system, it is diagnostic criteria: acid past but still seen in the cerebrospinal fluid. Probable possible imaging in TBM. Imaging into abnormalities of TBM you can see in this picture. Search for extra CNS TB. It is necessary also. Principle of treatment of TBM. Treatment should be started early in suspected TBM. Multiple antimicrobacterial drugs are required. Drugs must adequately cross the blood CSF barrier to achieve therapeutic concentration in CSF. Drugs should be taken on a regular basis for sufficient period to eradicate the CNS infection. Intrathecal therapy is not required. The general consensus regarding the choice of drugs, dose and duration of treatment. List of antituberculosis drugs you can see here in this slide. In conclusion, central nervous system tuberculosis is a common elementary treatable disorder with protein manifestation. Early diagnosis requires a high index of suspicion. Careful bacteriology of CSF is as good as or better than molecular methods before starting treatment. CT or MRI showing basal meningeal engagement with a degree of hydrocephalus is strongly suggestive of TBM, and clinical outcome depends greatly on the stage of disease at which therapy is initiated. Thank you for your attention, and see you soon at our third lecture.